Good afternoon. Thank you for coming here, joining us today. And I hope this journey will continue for the next 5 years. I hope it will make difference for people around you. And it's the best time to think strategically about how we're going to do this. So we've got about an hour. We're starting a bit late, but we've got about an hour. We will, myself, Usman, our public champions will introduce ourselves and give some bullet points about the strategy. But the purpose of this meeting is to know each other better, to come with ideas, with vision about what we're going to do and how we're going to deliver. I will introduce myself. I know many of you. I don't know some of you, and I hope to know you better soon. Please come in. My name is Edward Chancellor. I'm an academic GP. I work at the University of Liverpool. I'm cardiologist by background in the past, so there probably where my heart still sits. My colleague Usman will introduce himself in a couple of minutes. And depending on how many of us today, we might offer people to tell who they are. If we don't have enough time, we will ask you to introduce yourself when you present your ideas. I've added, is it working? So I've added a couple of slides, which probably was too late to update, but essentially I will see on my bullet points on the screen. So we are one of 7 themes, including 2 cross-cutting themes. Pete, do you want to see that there are some chairs? So yes, our ambition is to make Northwest and UK healthy and more equal place. Healthy and equal are 2 keywords in long-term condition themes, and it was mentioned today in the discussions. We'll keep them in mind throughout. We need to join our expertise as clinicians, as methodologies, with expertise of our public advisors and champions who know the needs, and we will follow their needs throughout the project. Hayat was mentioned today. We'll see how we implement it, starting from the earlier stage of the work we do. We need to prioritize resources. We don't have unlimited resources. It's not only about ARC, it's about NHS, it's about the country. So to achieve this, we need to have a vision. And today we will talk about the vision, how what we do will change equality, will change the practice and make better health. We need to think about the vision of any projects we do from the day of conception to the date of how they're going to be implemented. There is no small or big projects. They all need to be part of holistic approach. You heard earlier today about the role of industry. Industry becomes closer to academia. I personally don't think it's a bad thing. That attitude to industry has been changing, certainly in primary care, sometimes to a point that we are scared of industry. But industry can be ethical, and we want to deliver what we deliver at a high standard, something that we can match the expertise of industry and benefit from their innovations. And finally, we want to leave a legacy of the work we're doing, something that will stay in NHS, in social care, and something that we can be proud and people can build on in the next iterations of ARCs. I will have a few more slides about data in a moment, but Usman, do you mind if you introduce yourself?
Thanks, Edward, and thanks for the introduction. This is me. My name is Usman Alam, and I'm a endocrinologist, diabetologist, and an academic clinician based at the University of Liverpool. And my clinical work is primarily based at Aintree So the work I tend to do is based on diabetes complications. Obviously, diabetes is a chronic long-term condition, and hence why I've now involved in this theme. So I've also been described as a magpie by someone because I find shiny things and I tend to sort of do the work in those areas. So my work spans a number of different areas, including cardiovascular disease, diabetes complications, pain management, which is due to diabetic neuropathy. It's one of the major complications. And also most recently, AI. Some of the pain work I do is actually pain mechanistic, as opposed to sort of applied research. So I'll tell you a little bit about my journey. I started off, probably you can tell from my accent, in and around Manchester. Did lots of my training around there. Did my PhD there, but they decided they didn't want me for some reason, so I came to Liverpool instead. So I've been here for 9 years, and it's been, it's been a really, I've had an excellent time, met lots of brilliant people, and I managed to get involved in a number of different areas of research, including obviously ARC, and I'm really looking forward to working with everyone moving forward. So I probably don't recognize that many people in the audience, so it'd be great to get to know everyone, and I'm very much looking forward to the next 5 years.
Thank you, Usman. Now, our team gets bigger, and I'm really pleased to introduce our public contributor champions, Alan and Sandra. I think they can introduce better themselves. Uh, we, myself and Usman, we're relatively new to ARC. We're still learning. Sandra and Alan, they've got legacy of ARC 1. So we want to learn from their experience and prioritize something that we know is more likely to work. Alan, do you want to come here to introduce yourself? Or you, please do.
Yeah, thank you. I know, Sandra, you're going to say something as well. Yeah, good. My name's Alan Griffiths. I've got multiple long-term conditions, and I'm in receipt of far too many drugs. 13, I think, is the current number. They are trying to reduce the number, but who knows whether they'll succeed or not. I've always thought of multiple long-term conditions as being an unintended consequence of people living longer. And to explain that, when I first started work, at the end of my very first week at work, there was a retirement, and the poor fellow who was retiring was absolutely gutted. He just wasn't happy at all. And somebody explained to me that back then, I was 18, by the way, so it was like, oh, must have been at least 10 years ago. So apparently back then, a third of men didn't reach 35. And of the 2/3 that were left, only half of them reached 70. So that meant that the average life expectancy of a man was about 67. Now, I believe it's about 82, 83. Yeah, quite a considerable difference. However, the healthy life expectancy is only about 61. So back in those days, you didn't have people getting multiple long-term conditions because they died about 6 years after they started picking up the conditions. Now they've got them in 20 odd years. In my case, I got the first one at the age of 59. And I won't go into the details, but it was almost like one every other year, and they're still counting up. And one of the projects I'm involved in, the Dinerex, or Dinerex, if you prefer to call it that, there's one of the other, I think there are 8 projects related to each other around the country. And one of them, they're looking at clusters. Now, the one that always rings my bell, because I remember, because I've got this, I got type 2 diabetes. No, I didn't. Sorry, I got hypertension followed by type 2 diabetes. And apparently that's extremely common. And this particular project, they're looking into other similar things. But apparently that's quite common. I'm hoping to see lots of impact. And that can come in one or two ways, I think, and I'm sure we will. I mean, we've been talking and got exactly the same target, I think. There, impact can be in the form of people getting healthier, maybe fewer long-term conditions or fewer than people have at the moment. Another one, of course, could be saving the NHS a lot of money, reducing people's, polypharmacy, for example, can save an absolutely enormous amount of money. So I think that's about all. There's a couple of other things I've written here, but I won't bother. I've used all your time. Thanks.
Sorry, that's better. I'm a little bit little. So yeah, my name's Sandra Smith, and I've been involved from the days of Clark. So I've been around for a bit of a while. The reason why I wanted to get involved with long-term conditions, and it's also about we're looking at children, because it's about, children don't really know how to look after themselves. So if we can advocate for those children, for their health, through the adults, through policy, through change, then as they grow into adult life, they'll then be able to understand how they can then look after their own health and well-being. Also, for me, it's about how we can educate people to actually have their own self-care. And I think that's one of the big problems, because, I'm out in the community a lot of times, and people have, the faith in that the healthcare is looking after them. But then when I explain to them about, person-centered complex care, is the care about you, or is it about a condition? And so it's about educating them on how they can speak with healthcare professionals, how they can advocate for themselves. And again, for me, everybody always says, all Sandra ever says is, we've got the research, dissemination, implementation, because as I always say, it's no use writing a paper if you're not going to do anything with it. But it's not just about implementation, it's about measuring that impact, but measuring that impact so we can actually measure the change for the benefit. And as I always say to people, when you go to your GP, say to them, this has affected my quality of life, because that's all what we all need in life. We all need a quality of life. And with what's happening now with talking about the age difference of how long you're going to live with long-term conditions, then that quality of life is being reduced. And so for me, it's about how can I help my fellow people, lived experience, patients and policymakers to say, let's change the quality of life by this research.
Thank you, Alan. Thank you, Sandra. So ARC2 will be a little bit different compared to ARC1. There will be a number of shifts that will reflect what's happening in the NHS. And today you've heard that digital AI database work starts playing a bigger role, that takes priority. It will be delivered by ARC2 using collaborations between different themes. And I wanted to, and it's not easy. It requires joint expertise of clinicians and methodologists and data scientists, not only data scientists, but also public and qualitative researchers who will inform what data science should work on. So I want you to outline where our focus could be, and this will be followed by surveys to understand where your expertise sits in the theme, and we will talk about sub-themes, our outcomes and priorities. I'm sorry, the slides don't show what I've prepared, so we'll have it in front of me. I don't think we can. Just bear with me. I will talk through my slides. We will have, I'll cover sub-themes in a second. So So we will need to link tech-enabled innovation with long-term conditions in cooperation, analog to digital translation, and that's part of an HR arc. So what do we mean under integration? So there are multiple digital systems, and they don't always communicate and work well together. The heart of digital systems that facing both clinicians and the patients is integrated electronic health records, and increasingly a portal to communication with patients, which is an NHS app. So if we make electronic health records better, and they can be shared across all the providers in primary care, secondary care, social care, we're likely to communicate better and have few mistakes if we miss something in the continuity of care. The potential of electronic health records that it can be a platform to implement management pathways. And part of the work we will do together with NHS and ICB is to develop new interventions, new pathways and services. They will only work well if they become part of healthcare infrastructure. We also need to promote holistic clinical decision-making that's informed by evidence. We'll be creating this evidence, and it needs to be implemented in a way that it doesn't disrupt the workflows of GPs. Quite often we hear the comments, and I'm talking as a GP, we will develop another intervention and you'll be able to talk to your patient. It needs to work in a way that I can fit it in the consultation, or we can set up additional consultation that make this intervention meaningful, given enough time and space for patients to understand what the information provided. We need to nurture best practices in data management and digital interventions. This includes personal summaries provided to the patient. NHS app and records, they increasingly become a means to communication with the patient. Patients can see what happens there. So if we put the information that they can look at when they're at home, they can recap and reflect what they were told in the consultation. And we need to learn how to use it better. We need to have standardized and better way to communicate with patients. A primary care is probably quite ahead of some other services. We've got email-based, text-based means contacting patient and getting feedback from them. So we need to integrate them in what we develop. And we also talk about the data. There is lots of data that generated across NHS. And lots of effort been done by Department of Health and Social Care to put it together. But it doesn't mean that we benefit from this data to the extent that as we can. So in the ARC, we'll try to develop expertise working with clinical data, extracting the data, cleaning the data, interpreting the data. And for this, again, we need a mixture of clinicians and methodologies. Interpreting the data is absolutely crucial. The data are not created for research. They're created for the needs of healthcare and clinicians. Quite often it's done for medical legal purposes or some quality outputs. So we need to extract the information that can inform new services and not to overinterpret them. We plan to focus on 3 data sets to start from. There might be more, but we want to work with them really, really well. We want to focus on Northwest SD secure data environment that links local data. The purpose of this data set is to provide snapshot what happens in our own population and something that happens right now, something that can be changed quite rapidly. The second set of data will be CPRD. It's a nationwide data set that collects information from GP surgeries, probably about 40% of them, and link them to secondary data. University of Liverpool has license to work with the data. Some part of it needs to have additional funding. They're quite straightforward data, but if a new researcher comes to work with them, there could be many barriers to understand their structure, to understand what medical code means, how to access, how to apply for them, how to get the permissions. So in the theme, we'll aim to facilitate this data access. We will also work with UK Biobank, which recently been on the news. UK Biobank is a amazing piece of information about 500,000 of people in the UK with data collected in 2006, 2010, and they've been followed in a very consistent, repeated way still. They're now linked to primary care data, 45% of them. And literally in February, there was a breakthrough. The major electronic health data provider will allow to link GP data there. Where we can benefit from this data, apart from it being a unique data set on its own, it's very easily accessible for those who get into data. The approval process is straightforward. It's not expensive to get into those data. It's a perfect opportunity for us to expand our internships to data-driven work. It's not easy to do to work with those data, but it's even easier if we can guide people and have established way how to educate them, how to train them, and have to SOP. We already started this work. And finally, for clinicians, it's beneficial to have the data presented in a very clear, consistent way. There is such an amount of information that it can be confusing. And we keep talking about dashboards and data flows, but there is real science behind how to make them usable. So again, we will learn how to do this together. So, and we've got resources for this. I can see a number of colleagues here who works with data. We will collect information from you to understand how comfortable you are with data. And there is no expectation that everyone will be data scientists. So this will still help us to plan the team and how we are going to support you. So person-centered long-term care. This will be what we'll be focusing on. Digital innovations in healthcare. We will be linked to national priorities, and there is quite a lot of work started in this space. I can give you an example of a project that we've been encouraged or asked to join. It's a project led by Department of Health and Social Care, who wants to bring personal devices and wearables into the NHS. The first step is to allow people to measure their blood pressure at home and to bring information in the NHS app. This project just started recently in Cambridge. It started in London, but the population in Northwest can be a bit different. So they're looking forward for us to support this project if ICB is interested. So it could be a good opportunity, and the follow-on on that project would be inclusion of wearables. We keep talking about wearables. It's such a complex field about certification of those devices, linking them. We don't want to overwhelm GPs with huge amount of information. And our analog to digital bridge, we had this introduction already today. So now I will go back to sub-themes. So sub-themes is, so it's not about digital technologies themselves. Digital technologies will be across all sub-themes. Sub-themes is about the medical fields areas that we want to prioritize. We perhaps cannot capture completely everything, if otherwise we'll probably dilute our resources. So thinking about sub-themes strategically and as something that we'll be focusing for the next 5 years is quite important. Thank you, all of you who already completed survey online, and this informed our initial outline of what sub-themes can look like. Perhaps we don't to have too many of them, perhaps 4. One of them already started to shape end of life and cancer. Professor John Ellishaw volunteered. I don't know if we've got online facilities. He may join us online for a few words. Other shortlisted topics that we'll be considering today, they're not full list: stroke, hypertension and stroke, cardiometabolic states. Hypertension and stroke has a lot of expertise in this room already, so we're considering hypertension and stroke round table. Children, multiple long-term conditions, including old age conditions, integrated care and transitions, mental health services. So those are broad topics. We need to finalize them, but most importantly, we need to find those areas where our expertise is, where our heart is, so that we are prepared to spend our time to devote to development those areas, seeing them eventually being implemented in practice. It's not a trivial task. So your voice here would be important. This was the reason we haven't rushed to finalize those themes. Now we've got our next steps. Oops. And then thank you very much. Now we've got a couple of surveys. Now I've been talking about data science and data, and I must admit I'm not technology guru. So I know they've been set up. Do you have them on apps? Taylor, do so active activity. Okay. I suppose everyone can access surveys anyway, so it will help us still to collect the information. So we will collect all this information today, and again we will approach this in a fair, open, transparent way, prioritizing the areas where we generally have interest. And I'm passing back to my colleague Usman.
Yeah, I think I'm just showing. Is the sound okay?
We can hear you perfectly well.
Yeah. Just one slide, so to share with you, because these are some preliminary ideas about how we can develop the end-of-life care and cancer sub-theme, and some research project ideas. The first is around the serious illness conversation program in non-cancer patients. And the serious illness conversation, listening to Alan's talk earlier from the patient perspective, is really about looking at long-term conditions and really having conversations with patients, not just about the illness, but what for them are their priorities, their concerns, their aims within their future life and within their future healthcare. And this format of having a serious illness conversation has a training program linked with it. It's first started over at Harvard University, and we've been working with clinicians in the renal department with renal failure patients, with our respiratory clinicians linking with COPD and people with advancing cancer, with Dr. Vicky Weiss in the acute medical unit, seeing how we can have these kinds of conversation about people at the front door of the hospital, and also thinking how this connects with both frailty and cardiology into the future. So I think the focus of this program is about having these open conversations and helping patients really having more understanding from their clinicians about what for them are the priorities for them moving forward, and their understanding of the disease within an understanding of their prognosis. For that, we're working towards a development grant with the NIHR program grant, and I think we would look towards employing the quality improvement expertise in ARC, but also patient engagement and also looking at equality of access of these conversations within society. Also the opportunity to link with an SME around AI development and what's called SimConverse, which is kind of an AI construct to improve communication skills. Second project is linked with the concept of 48-hour drug delivery of subcutaneous infusions. This methodology of delivering drugs is often used within palliative care, but on a 24-hour basis. So my colleague, Dr. Andrew Dickman, who's a pharmacist, a leading pharmacist, has looked at this and done work internationally with a survey of looking at how drugs are delivered subcutaneously. And there are some examples of countries that have 48-hour delivery. But if we were potentially to use 48-hour delivery within the UK, that would have benefits for our patients because their drugs would be changed every 2 days, not every 1 day. Also economic impact for healthcare professionals and potential economic savings within the healthcare system. So again, for that, we are working with the pharmacology department in the University of Liverpool, and we would need engagement around the economics of this, patient engagement, and again, linking with industry around 48-hour delivery devices. The third project is around enhanced care for MND patients and linking in palliative care for MND patients earlier in their trajectory. And with colleagues at Walton Hospital, developing an intervention that can be reliably integrated into their service and looking at the impact that has on patients, their carers, and also the economic evaluation around that. So those are three research projects that we have done some preliminary work on or starting to do some work on that we think would be really enhanced by being supported within the ARC programme. We also have potentially some PhD ideas. One is around the NACEL dataset. NACEL is the National Audit for Care at the End of Life. There is a large dataset. The NACEL audit occurs through all hospitals within England and Wales every year, looking at the quality of how they have patients who die in hospitals. And within that data set, there is a lot of information that's never really been researched. Some of that is around equity. Some of it is around quality of care. And some of it is around quality improvement. So this is a rich data source that we could work with to improve care of the dying across the country. And the second PhD idea is with colleagues in Clatterbridge, looking at how we can use electronic and digital ways of collecting patient-related outcomes in patients with advanced cancer. So how they can self-report and how that might trigger interactions with healthcare professionals rather than having to come to attend regular outpatient appointments, which really maybe is not the best utilization of our resources and certainly not the best use of patients' time as well. So looking at how we can integrate technology to improve, again, quality of life of patients and also use our resources as effectively as possible. So those have been our preliminary thoughts about how we can take this theme forward, but happy for other people to contribute to those ideas or to volunteer other suggestions in this space. So thank you.
John, thanks for that talk. Is there any questions from the audience? No. Oh, one question.
Thank you. Thank you. It's Janine Winsbottom. I'm consultant nurse in epilepsy at the Walton Centre. So I'm just interested in the serious illness conversations that were mentioned there. One of our serious conversations is around a risk of death. So sudden unexpected death in epilepsy is something that faces most people at some point if they're having active seizures, particularly tonic-clonic seizures. And it's a conversations that there's evidence is not done very well, or it's not done at all for some people. And how we got to know about that was families who'd lost an individual telling us of those experiences, which is obviously not a good way to be learning that. And this has been going on a long time now, and it's part of NICE guidance. But I'm just wondering in this sub-theme whether that would be something that would enter that, because I know that it seemed to be quite focused in the talk that we've just heard.
John, did you catch that?
Yeah, no, I could hear that very clearly. No, I think that would be an interesting area to look at, and the construct of the serious illness conversation, I think, can be adapted to different scenarios, such as the one you've suggested. We've also had conversations with our cardiac colleagues about patients with implanted devices, cardiac devices that have to be turned off with magnets, and how those conversations take place. And again, we're looking at how the serious illness conversation could be constructed to enable that. It also embraces the idea of training and education within that program as well. So more than happy to pick up that conversation moving forward. Thank you.
Right, thank you. Thanks, John. I think next we have an activity, don't we, Taylor? And what are they planning on? Oh, we've got it up. Right. Oh, there they are.
This is, if you're online, you can also join in. And if you've got any, what you've written at the end, you can put it in the chat and we'll collect in the results at the end. So you can still be involved if you're online.
So divide your page into four. And the four sections, we just ask you to write down the following. So this is the interactive task. What problem are you solving for section 1? Section 2, clinical outcome, quality of life, cost, access, outcomes that matter most. Section 3, study design, trial, survey, community-based digital. What type of study design? And section 4, if you had to prioritise two of the following, diverse patient needs, scientific rigour, patient convenience, speed of results, inclusivity, which would you prioritise? Oh yeah, that's section 4. So you can prioritise two of the following: diverse patient needs, scientific rigour, patient convenience, speed of results, inclusivity. Which would you prioritise? So maybe just work in a group as in your tables. And I'll give you, you've got about just over 5 minutes. So firstly, if you just think about the research question. Right, thank you. I know that was a short time, but we're just going to have to wrap up. Unfortunately now, there's not long left. We'll have to move on to the next session. Right, so I'm going to just go around the tables and see how you've got on with this interactive task. So the first table I'm going to pick on is the very far table there. Given that Mark's on that table, I'm expecting big things because it's got the director of ARC. We'll just maybe give Mark the microphone. So if you just keep it relatively short, about a minute each.
Okay, so sorry about this because it is me and I just started the conversation good that quick. I was talking about, we've got these injectables that reduce weight, and there are arguments that then shouldn't be on long term, it should be for 1 to 2 years. There's an expectation they'll be produced given in primary care, but there are quite strict rules about what we can do in primary care, which our secondary care colleagues don't seem to realise. And what we don't have easy access to is the behavioural support that enables people to maintain the weight loss after the injectable has allowed them to lose that weight and become a healthier weight. And so the risk is that they will rebound with all sorts of potential unknown harms after the injectable is completed. And of course, lots of people are doing this off their own bat outside the NHS. And again, as far as we know, they're not picking up any sort of social prescribing or other way of helping them change their diet, their approach to life, the way that their households view food and exercise and healthy living. And it's just kicking the ball into the long grass for a couple of years and then it all comes back again with a vengeance. So our question would be, could we come up with an acceptable, deliverable intervention that supports households struggling with weight and obesity to maintain a healthy weight after another intervention to help them reduce the weight that they've gained, I think. And I was thinking on my feet. But that's entirely me. There were nods around the table, so I think I hit a nerve.
As a diabetologist, I think that's certainly a clinical question. The studies have generally been a couple of years for most of them, and then after that there's weight regain. Table at the back.
So there's a diverse group of people on this table, everything from weight management, suicide prevention, dementia, paediatric palliative care, adult palliative care. So there wasn't really anything that tied us together, but I guess we tried to think of the one thing that we thought of was report after report says that patients and families feel that they're not communicated with in a way which attends to their needs and wishes and understands their goals and helps them prepare and adjust to the conditions that they face. So that's a big question, that's a problem. In terms of how we were going to solve that, I don't think we'd gotten that far really.
Not solving it, just the question, the timely
yeah,
family-centred.
Yeah, but that's, I guess that's the big question, and I guess it affects all of those outcomes in terms of clinical outcomes. We know if patients are communicated in a way that attends to their needs, then they respond better to treatment, take treatment better as well, improves their quality of life, reduces admissions, unnecessary admissions, reduces access as well. So there is those types of things. How the study design, we didn't get that far, but I guess we glibly said, well, it'll all get reduced to AI chatbot. And I do think there is space for well-constructed AI chatbots to help triage in certain situations, but I think it's an interesting space moving forward.
We'll move on to the middle table.
Okay. Yes, we did quite a bit of introducing ourselves, so we were sharing all of our experiences. But I was I'd raised the query of the research question or problem was identifying people who were living with multi-comorbidity, many of which are long-term conditions in their own right, and how those individuals may not then identify themselves within the community as such, and so looking at maybe how that could be directed into an outcome, maybe the connection of those individuals, maybe self-management, and this was me brainstorming after the discussions. Obviously community-based, I think, was a focus, and we didn't get onto section 4.
Okay, right, thanks. So just move on to that table if you just... Right, thank you.
So we had a few conversations, but I think probably the main thing we were thinking was that we need to prevent both first and subsequent strokes. So we need to improve primary prevention. And I guess you could include primary prevention, well, as people having transient ischemic attacks, so TIAs, what people would call a mini stroke, but there are things that we could pick up better, risk factors for stroke in the first place, but then once somebody's had a stroke, we should make sure they get properly investigated such that that makes it less likely they have another stroke, and also that we make sure that they have interventions that can help them improve their quality of life, whether that's psychological, physiological, physical, whatever. So we need better primary and secondary prevention pathways, which not just affect clinical outcomes, but also quality of life. And actually that would decrease costs overall.
Right, thank you. I think our time is up, so for myself, Edward, Sandra and Alan, I'd just like to say thank you for attending this session, and you know, we're all here. If there's any further support needed, you know, we're just at the end of an email. And I'll just hand over to Edward for some closing comments.
Thank you very much again. We didn't have time to speak about through everything we mentioned over the tables. If you can kindly summarize with your words, your ideas on the pieces of paper, we will take them seriously. We'll look at them, and it will help us to inform our next steps. There is a survey which I initially hoped we would be able to complete here and to see your answers. If you can kindly complete it online, again, we'll use this information to inform our plans. Thank you very much indeed.